lives. Now, please join me in welcoming Sharon Wood for the occasion. Thank you.
Knowledge is power. Knowledge is shared, is powered, multiplied. Again, knowledge is power. Knowledge is shared, is power multiplied. Good morning to all. I am Charmette Sharon Wood, and it is my pleasure to share with you the occasion for today. The dictionary defines the word occasion as a special event or time, a chance, or opportunity. This morning, you are attending a special event hosted by the Palm Beach County chapter of the Charmettes, Inc. for the opportunity to experience an engaging, encouraging, and informative event on gallbladder and bile duct cancer awareness. The members of the Palm Beach County chapter of the Charmettes, Inc. are serious about eradicating all forms of cancer, which is why we are grateful for your presence this morning, and we look forward to your presence at all occasions hosted by the Palm Beach County chapter of the Charmettes, Inc. As we continue our purpose to support, encourage, strengthen, and inform our community on any form of cancer, it is our hope that you will enjoy the informative presenters and learn something about gallbladder and bile duct cancer that may help save a life. So again, I say to you this morning, enjoy this occasion on learning about gallbladder and bile duct cancer. Enjoy the morning.
Thank you so much, Charmette Wood, for that lovely occasion, and to Tammy for that welcome. Thank you so much, ladies. Charmette Leola, are you there? Can you make sure that I'm able to share, please?
Yes, ma'am.
And now we will have our Charmettes in Action video, our national video.
Cancer is a broad group of diseases involving unregulated cell growth. In cancer, cells divide and grow uncontrollably, forming malignant tumors which may invade nearby parts of the body. For many reasons, African Americans have the highest mortality rates of any racial and ethnic group for all cancers combined, and for most major cancers. Diagnosis and the treatment of cancer have great impact on individuals, families, groups, and communities. The Howard University Cancer Center has been a part of providing service and cutting-edge research cancer treatments for over 40 years. As the singular standalone cancer research center related to a historical Black college or university, HUCC has a rich history and demonstrated commitment to providing cancer treatment services and clinical research to support the mission of reducing the burden of cancer with emphasis on the impact on persons of color. The University Cancer Center serves as a part of a global community and enjoys relationships and the support of a number of institutions and organizations to further its work. Our contributions to the Howard University Cancer Center support preventive education and research, specifically through the center's Cancer Research Catalyst Grant and its Cancer Education Award. The Catalyst Grant undergirds development of long-term and ongoing research, which examines the reduction of factors related to cancer disparities. The Education Award supports student research and activities designed to enhance community education and engagement. We know that by working together, we can make a difference. When Frankie Drayton Thomas and Gwendolyn Baker Rogers founded the Charmettes in West Palm Beach, Florida in 1951, they envisioned a circle of friends using their resources to help the community to grow and prosper. The Charmettes understand that individuals working together can make a difference. And in communities around the country, Charmettes are actively involved in education, mentoring, and providing services for senior citizens and others. From that first group of women, the organization grew into chapters who now work in Florida, Virginia, South Carolina, Washington, D.C., North Carolina, Tennessee, and Georgia, all with a shared commitment to support cancer research and services and to finding a cure for cancer in our lifetime. From the inception of the idea, Charmette chapters were most enthusiastic about developing a relationship with Howard University.
The idea was brought to us by our founder, Frankie Thomas, one of our founders. She insisted that we support the work done by the Howard University Cancer Center because it is directed primarily at minorities, African Americans.
Never in a million years did I think we would have this collaboration going on all of these years. And I couldn't imagine the amount of monies that we have raised and how we've brought in the other chapters to help do this.
And from the initial fundraising contribution of $3,600 in 1981, our contributions have grown tremendously each year. To date, the Charmettes have contributed over $500,000 to the HUCC.
These funds are given without asking, without applying for it. I found them to be a very generous and outgoing group of people.
In 2006, in recognition of this unique contribution, the university named the Infusion Center for the Charmettes and co-founder Gwendolyn Baker Rogers. In this center, patients, many of them from underserved populations, receive necessary life-saving infusions. For more than 3 decades now, this national organization of women committed to community service have been educating, raising funds, and providing services to those who have been touched by cancer. Of course, we are only able to do this because of the fantastic support we receive in the communities where we work and live. The Charmettes work in partnership with any number of local and national organizations, and we value the support we receive from each person and every organization. Each year, the Charmette chapter that provides the largest contribution to the project is recognized at our annual convention. So to you, the people and groups who continue to provide support and encouragement for what we do, we thank you for what you have done. We thank you for what you are doing, and we thank you for what you will do in the future.
Thank you so much, everyone. So we hope you enjoyed that lovely video. At this time, we will have a video presentation by Gwendolyn Kelly.
Good morning, everyone. Today, we're going to show you a short video from the National Geographic Society. It's called Cancer 101. It's a brief introduction of how cancer forms and develops in the body. This video provides a glimpse into the terminology used when dealing with cancer diagnosis. Some data is provided about the various types of cancer. Sit back and hopefully you'll be learning so much from this brief video.
Today, but how does cancer start, and what is being done to combat it? Today, cancer causes 1 in every 7 deaths worldwide. But how does cancer start, and what is being done to combat it? Our bodies contain trillions of highly specialized cells, and each carries genes responsible for regulating cell growth and division. But when a genetic change disrupts this process, cells begin to grow and divide uncontrollably, thereby becoming cancer. The genetic changes that cause cancer usually happen in 3 types of genes: proto-oncogenes, which signal a cell to grow and divide; tumor suppressor genes, which signal a cell to stop dividing; and DNA repair genes, which preserve and maintain genetic codes. Changes in these genes lead to abnormal cell growth, resulting in masses of tissues called tumors. Tumors may be benign, meaning that they remain in one area, or malignant, which means that they are capable of spreading. Through a process called metastasis, a malignant tumor's cells will eventually break off, travel throughout the body, and begin forming tumors in other regions. When this happens, the cancer has become metastatic and is most dangerous. The cause of cancer is still a mystery. Inherited traits may be behind some of the genetic changes that lead to the formation of cancerous cells, and so might environmental exposures, such as excessive radiation from the sun or chemicals in cigarette smoke. In the United States today, roughly 1/3 of all people will eventually develop cancer. Of the over 100 different types of cancer, breast cancer is currently the most prevalent type, and lung cancer causes the most deaths. But our ability to fight cancer is improving. Since just the 1990s, cancer mortality rates have dropped more than 26% in the US, and more than 2 million lives have been saved. As treatments and methods of early detection improve, and doctors, scientists, and the public better understand cancer, hope remains in the fight against the disease.
This video, although brief, it was very informative and encouraging, as many gains and efforts have been made in the fight against cancer. So now I give you Ms. Sharonia Godfrey, who will introduce our first presenter.
Good morning again, everyone. On behalf of the Palm Beach County chapter of the Charmettes Incorporated, I would like to introduce our first presenter this morning, Dr. Shantel Bhagwandin. Dr. B, as he is affectionately known, is the medical director of Gastrointestinal Surgical Oncology program at Jupiter Medical Center. Dr. Bhagwandin specializes in the diagnosis and treatment of benign conditions and a wide array of cancers, including complex or recurrent cases utilizing the most recent advances in technology. His areas of specialization include bile duct cancer, colon and rectal cancer, esophageal cancer, gallbladder cancer, liver cancer, and colorectal liver metastasis, pancreatic cancer, peritoneal surface malignancies, skin cancer, soft tissue sarcoma, and stomach cancer. It is truly a pleasure to have Dr. Bhagwandin joining us this morning. Please help me welcome Dr. B. If you have any questions during Dr. B's presentation, please post them in the chat box. The chat box will be monitored during his presentation to ensure your questions are answered in the Q&A session immediately following the presentation. Thank you. And now I will turn it over to Dr. B.
Thank you very much for that introduction. So I really want to extend a thank you. It's an honor to speak to the Palm Beach County chapter of the Charmettes Incorporated, and really an opportunity to talk about what I do. More specifically, like Sharon said, knowledge is power. And I think it's important, especially when we are dealing with rare cancers, but not only high-risk cancers that affect our demographic. And really the key is an early diagnosis, it's important, especially with these cancers, to pick them up very early and certainly know about them so that the workup and symptoms are addressed, because a lot of the times they are very vague and non-specific. So I'm going to be talking a little bit just about what's called a multidisciplinary treatment, and it really is just more so the comprehensive approach to gallbladder and biliary tract cancers. I am the medical director for GI Surgical Oncology, which means that, you know, this is an area of expertise for me with regards to cancer surgery. I treat bile duct cancers, pancreatic cancers, and in a way, when some patients ask me what I do and I explain, they don't necessarily want to know me, but at the same time, it's one of those things, if you know someone or you are afflicted with this type of cancer, you do need to see someone that has the expertise to have the best outcomes. So with that, I have no disclosures. I just want to open with a quote from Alfred Blalock, who is a historical figure in surgery. He's a pediatric heart surgeon, chairman and former chief at Johns Hopkins, but he did pioneer a procedure with Helen Taussig almost 100 years now, where he was able to treat pediatric heart conditions known as blue baby syndrome, more specifically tetralogy of Fallot. While he was chair at Johns Hopkins, he obviously looked over a lot of other surgeons, and he stated that in malignancy of gallbladder, when a diagnosis can be made without exploration, no operation should be performed, in as much as it shortens the patient's life. Now, I'm going to challenge that a little bit, because obviously that was in the context of when gallbladder surgery was done through an open incision, whereas now the majority of the time we're able to do it laparoscopic or robotic small incisions. This is a graph that shows a little bit of our specific incidence for some of these cancers that were referenced in the previous video. This is our zip code, specifically more Palm Beach County. And what I want to point out here is just the 5-year and 10-year growth of cancer mimics the rest of the nation, but more specific to Palm Beach County, we're seeing a lot of cancers increase. And you'll see just in the column with regards to the growth, it's all green, it's all going upwards. There's not a decrease or a decline specifically with regards to any cancer. And I think that's why awareness is key. That's why we're having this conversation, and at least pointing out specific to where it hallmarks bile duct cancer, liver cancer, et cetera. We're seeing a significant jump over the next 5 to 10 years with regards to growth. So I think it's a good opportunity for us to take away, learn a little bit about this disease, and you know, be able to share with someone and potentially save a life. So this is a complicated subject. These are rare cancers, so not many people know about them. And at the same time, where you have other cancers that are not, they are common, but in a way they don't necessarily get a lot of spotlight, meaning that just this past year, we had a number of celebrities that died from pancreatic cancer, specific to colon cancer. Chadwick Boseman passed. And those are opportunities that do shed awareness. But in the context of gallbladder cancer, bile duct cancer, those are very aggressive and rare type of cancers that move very quickly, that sometimes you don't get a lot of the spotlight, or at least awareness, that is necessary to understand these diseases. So I do recognize that they are complex diseases. And in a way, what I want to at least speak to our audience today is to take away something that specific to this talk that you learned, that you might be able to explain to someone else. A lot of what we talk about with regards to gallbladder and bile duct cancers are more specific to the anatomy. So within the liver, bile leaves the liver, it gets stored in the gallbladder, and then from there, it travels down the bile duct into the intestine. So a lot of the cancers that we see along that pathway actually have different names, but they still fall under the same umbrella of biliary tract cancers. So up at the top, where cancers are in the liver or around what's called the hilum, or the entryway to the liver, are extrahepatic bile ducts. Once cancers go into the gallbladder, they're obviously defined by way of gallbladder cancer. And then when they exit the bile duct at what's called the ampulla, they're known specifically as ampullary cancers. Overall, this is a schematic that shows that pathway from within the liver down through the bile duct, and then it exits into the intestine. This is an example of an intrahepatic tumor in the liver, and then an extrahepatic tumor where the bile duct leaves the liver and then enters the and joins with the bile ducts for the gallbladder. Overall, these are aggressive cancers. They're more commonly diagnosed in elderly patients. They do portend a very poor prognosis. And a lot of that is just in the context of how they present. They usually present at later stages where we can't operate on them, and thus they're termed unresectable or inoperable. And a lot of patients will actually present with cancer that has spread to throughout the liver or to the lung. Obviously, as I said, I'm going to challenge the initial quote, which is selected patients actually do benefit from a surgical approach. The incidence of these cancers are approximately 2.5 cases per 100,000 people. Gallbladder cancer is the more common of all of the biliary tract malignancies, and overall in terms of GI cancers, meaning anywhere from the esophagus to the rectum and in between, gallbladder cancer does fall under about the 5th most common GI cancer. So it is something that we do need to be aware of. These cancers are also more common in women, and as stated, more than 75% of patients are over the age of 65. The distribution of gallbladder cancer specifically is more common in other countries than others. The rate in India is noted to be as high as 21 per 100,000, which is significant. That's usually the most. There are other countries that have a higher incidence of gallbladder cancer in South America, specifically Ecuador. Western European countries in the US don't typically see that incidence as high, whereas in the US it's more closer to about 1.2 for every 100,000 person. But with that being said, no one's necessarily winning the race, because the mortality, meaning the death rate from diagnosis with gallbladder cancer, is still very, very high, particularly in those countries that see it more commonly. The risk factors with regards to gallbladder cancer specifically is usually attributed to just chronic inflammation. The diagnosis there is usually cholecystitis, which means that the gallbladder is inflamed. And gallstones are usually noted in about 80% of patients that have gallbladder cancer, meaning that it's 7 times more common in patients that actually develop gallstones. And gallstones are usually just by way of diet. We develop cholesterol stones, but what they do predispose to is that chronic repetitive inflammation within the gallbladder. There's also a term called a porcelain gallbladder, which is a calcification in the wall of the gallbladder. And there are some hereditary syndromes known as primary sclerosing cholangitis, which affects the entire biliary tract from the liver to the gallbladder all the way down. And as a result of that, we do see gallbladder cancer develop in about 20% of those patients. But that's usually over a course of about 15 to 20 years, where those patients have that diagnosis for a long time. Polyps, which are sort of akin to how you would think of a polyp forming in the colon, leading to colon cancer. In fact, polyps can actually transform over time. They can grow and become a gallbladder cancer. One thing to mention, because I don't want to alarm anyone that has or knows that they have a gallstone, is that although the incidence of gallbladder cancer is higher in patients that have gallstones, only about or anywhere from 1 to 3% of patients that actually have gallstones will develop a gallbladder cancer. The point there is just that there's a sort of a repetitive inflammatory process that does predispose to that developing. So polyps, this is an ultrasound picture here on the right that just shows a polyp within the gallbladder. Again, it's a sac-like structure, and it stores bile. So the bile shows up dark on an ultrasound, but the polyp will show up bright white on there. A small polyp, less than 1 centimeter, which is about a fingertip size, is not something to worry about. But when we learn about polyps and we see that they are either growing or they are bigger than 1 centimeter, we do see an increased incidence of cancer in those patients, particularly if they get to be to about 2 to 3 centimeters. At that point, the recommendation is to do a laparoscopic cholecystectomy, which means that we remove the gallbladder. It's an outpatient surgery, and it's in the context of a preventative measure. Obviously, if a mass is encountered at the time of the gallbladder surgery, the recommendation there is to convert that operation to an open incision for fear of spilling or seeding the abdomen with a potential cancer. Mass is synonymous. It doesn't necessarily mean cancer, but it just means that there's a hard tumor there that is notable and could potentially be consistent with a cancer. But masses can always be benign, meaning non-cancerous or non-malignant, or cancerous. Usually polyps, unless they're located in the gallbladder neck, which is the junction of where the gallbladder joins the bile duct, they won't typically get big enough that they create a blockage in the bile flow. So most patients will actually be asymptomatic. And these are usually found just for routine workup for potentially pain in the right upper quadrant or symptoms that may be a result of a workup for gallbladder surgery. There are many different types of gallbladder cancers. The more common one is an adenocarcinoma, and about 75% of gallbladder cancer. And again, these cancers are the more aggressive types of cancers. The prognosis, meaning how long do you have to live when you're diagnosed with a gallbladder cancer, is all dependent on stage. And I'll explain a little bit about what that means with regards to cancer. But overall, just the diagnosis of cancer, if you look at everyone that has had a diagnosis of gallbladder cancer, and you look over a 5-year period of how many people are still alive at 5 years, it's only about 1 in 10, or 10 in 100. And that's actually a very poor survival. It means, and it supports what I'm saying, that most patients present with very advanced disease, that at the time of diagnosis, ultimately the diagnosis is shortened. I personally don't feel that it's fair to necessarily put a number on survival with regards to that question, how long do I have to live? Because no one really knows, based on the staging, how a patient may or may not respond to chemotherapy or surgery. The question therein, though, is whether or not that survival will actually be better based on an operation. But if you do have to offer some guidance with regards to, well, what's the likelihood of being alive at 5 years? That's where that overall survival comes in, and it does give us some idea of prognosis. Most patients, though, once they are diagnosed with gallbladder cancer, 50% of them usually succumb to that disease within less than 6 months. This is a picture of the gallbladder here connected to the bile duct, and the specific name for that is called the cystic duct. So when someone has a surgery for the gallbladder, it's actually a division of the duct here, and the entire gallbladder is removed, not just the stones or not just the bile. We actually remove the entire gallbladder. And what's not pictured here is that the gallbladder is actually attached to the undersurface of the liver. Within the gallbladder itself, we usually find that more cancers are located in the fundus, which is almost the belly of the gallbladder here. 30% of them occur in the body of the stomach, and then about 10% occur in the neck, which is the junction of the cystic duct and the gallbladder. And that's usually where patients have symptoms from gallbladder stones, is that a stone will get lodged in the neck of the gallbladder, which is why we develop symptoms. There are many different staging classifications, but this is just a cross-section of the gallbladder here. And cancers will start on the inside of the gallbladder and grow through the wall. And this is just a slide here that shows the different layers and the different staging. So once a cancer grows from within the lining, the inner lining known as the mucosa of the gallbladder, it could then start to grow through the wall. And then once it becomes a T4 tumor, it's growing out of the wall into the attached liver. So that obviously gives us a little bit of a better idea with regards to staging. And it also gives us better guidance with regards to how to treat this. The question is, why is gallbladder cancer so aggressive? Why does it present at such a later stage? Why does it move so quickly? And a lot of it has to do with the lymphatic drainage as well as the venous drainage. We have lymph nodes throughout our entire body, and just similarly within our organs, we have lymph nodes that drain those organs. And when a cancer develops in the gallbladder, there are a lot of lymph nodes around there. There are different stations around the pancreas, around the bile duct, the arteries, etc. And because of the very robust nature of drainage from the gallbladder, these cancers, once they start to trickle into the wall, they can then gain access to the lymph nodes by way of lymphatic channels. That's sort of the on-ramp to the highway that allows these cancers to move through our bodies. Similarly, because the gallbladder is attached to the liver, it can also grow directly into the liver, and as a result of that, gain access to the liver's venous supply and lymphatic supply, and as a result of that, spread throughout the body very, very quickly. So this is a picture of a CT scan. A CT scan is basically X-rays, but it uses almost a 2D reconstruction of those X-rays to give us a better picture. When people have a CT scan, they're usually laying on their back, which is down here. This is the right side of the body, and this is the left side of the body. And a CT scan is almost like you're laying on your back and sliced like a loaf of bread. So the CT scan allows us to go all the way down and look at different organs in different dimensions. This is a picture of the liver. And what these arrows are pointing out is that this density, this darker area within the liver, is actually a mass that's growing up from the gallbladder into the liver. And as a result of that, these arrows are showing the dilated bile ducts. You don't see the bile ducts as dilated here, but the issue is that this cancer is growing into this side of the liver and blocking the bile ducts from draining there. So as a result, patients develop jaundice or yellowing unless this side of the liver can compensate. Where that correlates to staging and how patients are diagnosed is that most patients will either have gallbladder cancer when it's diagnosed where it's contained to the gallbladder itself, or it's growing up alongside of the liver or into the liver. That's usually a stage 1, 2, or 3. That accounts for about 50 to 60% of patients. The additional 40% of patients are considered stage 4, which means that that cancer has spread distantly in the liver, not directly from the cancer itself, but distantly in the liver, or it's spread to the lung or another organ, or the cancer is actually seeding the abdomen, which means that it's spreading throughout the abdomen. A lot of the symptoms are indistinguishable from just gallstones, where patients may develop pain in the right upper quadrant specifically. Over a period of time, patients can develop rapid weight loss. They'll have a loss of appetite. And when the gallbladder becomes inflamed and it becomes mass-like, you can almost feel a mass there on exam. Obviously, once it grows into the bile duct and creates blockage, patients can get yellowing of the eyes or jaundice. The diagnosis is typically follows the pattern, or at least workup with regards to gallbladder and gallstone disease. So most patients will start with an ultrasound, which may show the mass or some thickening in the wall. And that usually has a sensitivity of anywhere from 70 to 100%, meaning that it's relatively good for picking up a problem with the gallbladder, be it stones or a cancer. Usually that prompts either a CT scan or an MRI, and the CT scan will show more specifically if the mass is growing into the liver, as well as if the bile ducts are blocked. And then there's a special test called a cholangiography, which is just a fancy term to say that we can look within the bile duct itself to see whether or not there's narrowing or impingement on the bile duct. That can be done one of two ways, where a GI doctor can bring a scope down through the stomach, enter the intestine, and access the bile duct from below, and essentially do that imaging to see where the bile duct may be blocked from the inside. Similarly, a radiologist may be able to pass a needle and a catheter into a dilated bile duct in the liver, not pictured here, and similarly put some contrast in, which highlights the duct and allow us to see how far it goes or where it's actually blocked. Jaundice is usually a symptom that happens with that, or when that happens. And that actually is a very poor prognostic sign, meaning about 85% of patients with jaundice can't have an operation because it's so involved, it's invasive, it's growing out of the gallbladder into another structure, which is the bile duct, or into the liver and creating a problem. And usually at that point, it's invading blood vessels and things that a surgeon can't safely remove without causing failure to the liver. How this is usually diagnosed is incidentally, meaning that patients either have an ultrasound workup or a symptom that prompts imaging, but more commonly, it happens when you're in the operating room removing the gallbladder, and then intraoperatively, you either recognize that there's a mass growing from the gallbladder to the liver, or once the gallbladder is out and the pathologist looks at it under a microscope, they find an incidental gallbladder cancer. That happens in about 1% of patients, meaning that if they go to the operating room to remove a gallstone, or rather the gallbladder because of gallstones, there may be a gallbladder cancer hiding there in about 1 out of every 100 cases. And gallbladder surgery is one of the more common surgeries that's done by general surgeons. So it's important that if something like that is found, it's managed appropriately by a cancer surgeon. That management, again, depends on the stage of that cancer. And certainly if a gallbladder cancer is suspected while you're in the operating room, again, the recommendation there is to do an open operation, because if the gallbladder is accidentally entered, what can happen is that it can seed these cancer cells throughout the belly. So the recommendation, again, is to convert the operation, which is typically laparoscopic, to an open procedure, which is why that's usually on the consent, is in the event that something like that happens, or there's an injury or involvement to the bile duct. We often, when we're removing the gallbladder, will actually place it in a bag before pulling it through the skin incision. And that's something that actually became standard of care because incidental gallbladder cancers, again, it doesn't happen often, about 1 in 100, but the idea is you're at least protecting the gallbladder from rupture of bile, spillage, or the potential for a cancer. Similarly, if a gallbladder cancer is picked up on imaging before surgery, biopsies are typically not recommended, because how they're done is by directing a needle into the tumor, and the needle that's pictured here actually has a core. So as it goes into the tumor, it creates basically a cylinder of tissue, and then this slides over top and protected on its way out. The issue is that usually that tract will seed cancer on its way out because of small cells. So specific to gallbladder cancer, we usually advise against that. Unless, of course, we've recognized that the patient's unresectable, meaning we can't do an operation, and it doesn't make sense to put them through an operation to get a diagnosis. Usually at that point, you can do a needle biopsy, which is through the skin into the mass, and a diagnosis is delivered in order to give chemotherapy. If a general surgeon diagnoses a gallbladder cancer, the patients usually refer to myself as a surgical oncologist, because we do a more involved operation after that diagnosis, which I'll explain, to treat the cancer. It isn't treated usually by just removing the gallbladder. In order to complete the staging workup, we usually start by putting a camera back into the belly. And the reason being is that the laparoscopy, putting the camera in, will pick up very subtle spots in the liver that won't show up on imaging, be it CT or MRI, no matter how good the imaging is, because gallbladder cancer is very subtle. It can grow through the liver, and things that aren't big enough to show up on imaging won't do that. So when you see it with the naked eye, it tells us that there's likely metastatic disease or it's spreading. And the yield for doing that is about 50% in stage 3 cancers, meaning that although the surgeon may not have seen it during the first operation to remove the gallbladder, which is pictured here, going back to do a more definitive operation, it's important to put a camera in and take a look around, because that's one way that you can pick up something that can very well show up in just 2 or 3 weeks after surgery. That's how aggressive this moves. The liver is divided into 8 segments. There's a left liver, which is the smaller lobe, and a right liver, and there's 4 segments on either side. Segment 4 has 2 upper and lower segments, and then segment 1 is in the posterior aspect of the liver. Where the gallbladder resides is in between segment 4 and segment 5. So what a surgical oncologist, a cancer surgeon, does to go back and treat when a gallbladder cancer is we go back and we remove this area of the liver where the gallbladder was attached, because there's a very high percentage, upwards of 50 to 60% when we do that that there's still residual cancer there, meaning that even if you remove the gallbladder, there's likely still cancer that's growing into the liver. So the more definitive procedure is to do just that, to remove the 2 segments and then remove any surrounding lymph nodes to help with staging. Once a cancer has been documented as being advanced, there are many roles for chemotherapy because, again, we want to prevent these cancers and these microscopic cells from circulating throughout the body. And once they get on that on-ramp to the highway, they can do just that. When I'm treating a cancer, I'm not so much worried about what I can see or what I know is there. It's more so specific to what we can't see. And that's really the way I look at chemotherapy, is that it's treating the whole body. The potential for these aggressive cancers to come back, and in this particular case, about 85% of the time, the cancer does come back. So when you have data that supports that these cancers can come back, the idea is that if you can treat with chemotherapy after surgery, you're decreasing the likelihood. And again, there's very few trials that support that, but there are effective chemotherapy regimens. And the reason why the trials aren't necessarily well established as far as effectiveness is that a lot of patients ultimately succumb to the disease even throughout the treatment plan because the median overall survival is 6 months. When patients have stage 4 disease or it's spread elsewhere throughout the body, at that point, we don't offer a surgery. It's actually contraindicated. And at that point, the treatment options are either chemotherapy, or if the patient's not a good candidate for chemotherapy or is opposed to treatment with chemotherapy, at that point, we focus on palliation, which is a term that is used to say that we're going to treat the symptoms, focus on quality of life, and make sure that the patient isn't in pain. If they have jaundice, that we relieve the jaundice by decreasing the blockage in the bile duct. Again, the overall survival with regards to gallbladder cancer is less than 10%. And then broken down by stage, early stage cancer, T1 or stage 1, means that 5-year survival is actually upwards of 95%, meaning that if you actually take all the patients where the gallbladder cancer was found just within the gallbladder itself and it didn't grow through the wall, that's a very early cancer. Again, it's only in about 25% of patients, but patients can actually live to cure, meaning that at 5 years, 95% of patients are still alive with that staging. But when you get more advanced disease that's either growing into the liver or into the surrounding lymph node, even with a liver resection, that survival is a lot better, meaning that if you just remove the gallbladder versus do a liver resection, the survival jumps from 18% to 60% still alive at 5 years. But again, it's a lot less than if it were earlier. And again, stage 4 disease is metastatic disease. That carries with it a median survival of only 2 months. So at that point, I don't see much of a benefit with chemotherapy. There really is focusing on quality of life and symptoms. So in summary, obviously, this is a very aggressive disease. Staging is key to how we determine how to manage these. And not all patients without metastatic disease require surgical evaluation. These patients should be seen by a surgical oncologist. They should be seen to determine whether or not there's more advanced disease, as well as do the appropriate operation. Switching gears a little bit to the rest of the biliary tract malignancies, the bile duct cancers exclusive of gallbladder cancer, is something called cholangiocarcinoma. That is another term for bile duct cancer. And essentially they come and arise from cells that are in the bile duct, either within the liver or out of the liver on that journey down into the intestine. In this particular incident, the men actually have more common diagnosis of bile duct cancers than women. The risk factors, again, still speak to primary sclerosing cholangitis. There are some worms and liver flukes that do pose a risk because they tend to reside in the liver. But again, those are in other countries where you may see them more prevalent, in India or in South America. Bile duct cysts, otherwise known as choledochal cysts, are cysts that can form in the bile duct and cause sort of continual inflammation that over 15 to 20 years can lead to a bile duct cancer. Similarly, 90% of these are adenocarcinoma. And again, in terms of location, there's either in the liver or intrahepatic. There's perihilar, which basically means that it's just as the bile duct is entering the liver, which is the more common location for these tumors. Or there's distal bile duct cancers, which means down here. So it's either in the liver or outside the liver, but it's all the same bile duct. The survival, whether it's in the liver or out of the liver, differs because cancers that are discovered outside of the liver actually have a better survival stage for stage, except for metastatic disease. If a cancer is located out of the liver in the bile duct and it's localized to the bile duct, the survival is actually double what it is if it's just a bile duct cancer located within the liver. And again, that speaks to how aggressive these tumors are because they have access to venous drainage and lymphatic drainage within the liver. Once they spread to lymph nodes, the survival does drop, which is what that term regional means, that it's going to a lymph node nearby, but it's a lot less of a, or more of a survival if it's a bile duct cancer outside of the liver. The clinical presentation is very similar with regards to bile duct cancer. Certainly if it's in the liver, most patients have vague abdominal pain, distension, weight loss, and the potential for jaundice. But more specifically, if it's outside of the liver, it's usually affecting the drainage away from the liver. Bile actually gets backed up, and most patients will present with painless jaundice, meaning they have no pain, they just turn yellow over a period of a few weeks. These tumors have to arise at this junction of the right and left side of the bile duct or below it. And the reason, in order to develop jaundice, and the reason being is that if there's a bile duct cancer that develops here, the rest of the liver will be able to likely handle the bile flow and avoid developing jaundice. But obviously, as those tumors go undetected, they tend to spread. There are blood markers. So people say, well, how come we can't pick these tumors up sooner by checking the blood? There are some blood markers known as CEA or CA19-9, but they aren't very sensitive, particularly with regards to bile duct blockages, because they don't necessarily mean that you have a cancer if they're elevated. They often are used more as a prognostic marker after surgery. So how we diagnose this, and again, this is a CT scan. The right side is essentially normal, and the left side is abnormal. And I'll point out the things that I want you to take away from this, but essentially, these cancers, when they have masses growing into the liver, they do show up large on the liver, whereas this gallbladder here is normal. And then once they spread through the liver, there are two other spots here that can light up that can show that there's spread throughout. They can also show the extent of nearby blood vessels that are involved with these cancers, as well as lymph nodes. Again, as we talked about, the procedures to drain the bile duct are primarily more so if there's a blockage, either from above by a radiologist who puts a tube inside and gets the bile to exit the liver if it's blocked from below, or the GI doctor can access the bile duct from below and then put a stent inside, which opens it up. Ultimately, that's how these cancers are diagnosed, because they can pass a brush up the bile duct and essentially scrape it for cells and allow us to get what we call cytology or pathology to look under the microscope to diagnose these cancers. Very quickly, because I don't want to take away from our next speaker, but again, intrahepatic bile duct cancers, the survival with these cancers, if you're able to remove all of them, usually have a 5-year survival of about 40%. And that just speaks to the fact that about 40% of patients are still alive at 5 years, not that they only have 5 years to live. And surgery is obviously recommended for patients if you can remove all of the tumors inside of the liver. Similarly, if these tumors are at the junction of the right and left side, called perihilar bile duct cancers, the 5-year survival is typically about 20 to 40%. Most of those patients with the surgery can live upwards of 3 years. And again, we're talking about a cancer that the median survival is still only about 6 to 12 months, with the surgery, you can improve that to anywhere from 2 to 3 years. These cancers, because they do involve the bile duct, require a complex procedure, which involves removing part of the liver with the bile duct that's affected. And then we bring a piece of intestine up and sew it into the bile duct once the liver is removed, so that bile can then drain from the liver into the intestine directly. That's an operation called a hepaticojejunostomy. We do it quite often. Finally, when cancers are at the bottom end or distal end of the bile duct, they more commonly involve the pancreas because that's where the pancreas is located, and we have to do a procedure called a Whipple procedure to treat them. The 5-year survival, again, is typically about 27 to 44%. Most of those patients can live upwards of 1.5 years after surgery. Obviously, if cancer has spread or there are symptoms that preclude surgical intervention, the goal there is to relieve the bile duct blockage because there is a degree of pain, infection, and jaundice that comes with that. So that may be a component of bile duct stenting. And again, for the more proximal tumors, the higher tumors, you decompress the liver by sticking through the skin and accessing the bile duct, whereas the distal tumors usually require a stent to open that area. The chemotherapy regimens are typically the same. And again, that's really in the context of palliation if a surgery can't be done or there's more advanced disease. So almost 100 years later from Dr. Blaylock, and with all due respect, I would challenge and say that in malignancy of gallbladder, with careful patient selection, an aggressive surgical approach can actually have a significant impact on survival. And again, we're dealing with cancers that we're seeing more and more commonly. And as a result of that, it's important to have that specialization of care. I want to thank you again for the opportunity to speak and talk about this. And I'm looking forward to questions as well as our next speaker.
Thank you so much, Dr. V.
Thank you.
Can everyone see the agenda?
No.
Okay, so next on our agenda, we will have Felicia Harvey with our question and answer session.
Good afternoon. Thank you, Dr. B. Awesome presentation, very informative. We have 6 questions. If there's an answer you're looking for and you didn't put a question in the chat, just raise your hand and you will be recognized and asked. The first question for Dr. B is, what happens with the bowel if you don't have a gallbladder?
Good question. So again, bile is just stored within the gallbladder. So what happens is that for the most part, the liver will compensate by making more bile. So that way, if the gallbladder is not there, it will recognize over a period of 3 to 4 weeks after a surgery that more bile needs to be produced to help us digest our food. So what happens is that bile duct will then dilate up a little bit to accommodate for the missing gallbladder and deliver more bile into the intestine, because about 95% of our bile actually gets reabsorbed and recirculated from the intestine. So it does a pretty good job of that. But some patients can have diarrhea if they're just not getting enough bile into the system.
Okay, second question. How important is the gallbladder to the body? What is the lifespan once removed?
So the gallbladder itself, I would say, is not an essential organ because it's just there to concentrate bile and store it. So it's not something that by removing it, it would be anything that would necessarily limit survival. It's just, noticing that the function of the gallbladder is primarily to store the bile so that as soon as you eat, there's a rapid delivery of bile into the intestine.
Okay. Is the high incidence of gallbladder cancer in India related to their diet?
I think so. I do think that there is some component of dietary, factors that can contribute why. There isn't a lot of data that says specifically what within the diet, But especially because we see these diagnosed in ages over the age of 65, the potential there is that, especially with gallbladder disease, meaning gallstones, there may be a higher incidence of gallstones as well as chronic inflammation from gallbladder disease in those countries, particularly countries that have a more fatty diet.
The next question is, does alcohol use contribute to the incidence of gallbladder cancer?
Excellent question. Alcohol specifically has not been linked to gallbladder disease. It does affect, and it is a contributor for liver cancer, as well as the development of cirrhosis. Other environmental factors, especially with bile duct cancer, can be hepatitis, which is a viral infection. But alcohol and tobacco haven't specifically been linked as environmental exposures to bile duct cancers, but pancreas cancer certainly, and liver cancer.
Okay, the next question is, if I have suffered from occasional gallstones, does it mean I'm at higher risk for developing gallbladder cancer?
No, not necessarily. We do see, only about 1 to 3% of patients that actually have gallstones that develop gallbladder cancer. About, at least within the United States, about 20% of the population walking around right now has gallbladder stones. Most of those patients don't have symptoms, but certainly if you do have symptoms, that's an indication to get the gallbladder out. Particularly if those stones become more and more symptomatic, it means that they're developing inflammation, and those are things that can contribute to infection. But ultimately, no, not just having stones in isolation. They are, yes, the biggest risk factor, gallstones in particular, the biggest risk factor for gallbladder cancer, but it doesn't mean that you necessarily have a gallbladder cancer, but should be treated if symptomatic.
One more question. When the pancreas is removed, do these patients become diabetic?
Excellent question. So only in those particular surgeries where we have to remove the pancreas, usually we're removing the head of the pancreas, which is about 30 to 40% of the pancreas. The remaining pancreas that's there serves the function to produce insulin as well as pancreatic enzymes to help us digest our foods. So those patients do not become diabetic.
Our last and final question. Is the liver being overworked by producing more bile to compensate for the gallbladder removed?
Good question. The liver actually has a phenomenal ability to do that, because again, the bile duct cells and the liver cells can produce more bile if needed. But the liver itself actually, and the intestines actually recirculate the bile, and about 95% of it has an excellent capacity to do that. So it's almost like gasoline in a car, is that instead of burning off that gasoline, it's actually able to use about 95% of it. So the liver has a remarkable capacity to reabsorb that bile into our bloodstream and then deliver it back to the liver. So not typically anything that would lead to the liver being overworked unless there's a blockage or a problem, because that can lead to jaundice.
That's the end of our questions, Dr. B. Thank you again. Awesome presentation. Very informative. Now I will turn it over to Ms. Tara Thomas.
Good afternoon, everyone. On behalf of the Palm Beach County chapter of the Charmettes, Inc., I will once again like to thank everyone for taking the time out to take part of this with us in this event. Excuse me. Today, I have the distinct pleasure and honor of introducing our next speaker. She was a dedicated employee with the Palm Beach County Sheriff's Office for 30 years. And upon her retirement, she dedicated her sole focus to her organization, 10 Angels Forever, Inc., which she founded in memory of her twin sister, Tanya Ingraham, to educate and bring awareness about bile duct cancer. She is the proud mother of one son, Air Force Master Sergeant Leon Spence II. And in addition, I have had the pleasure of being one of her best friends for over 20 years. I would like to present to you one of the most courageous women I know, who has turned her pain into power. Please put your virtual hands together as I present to you Ms. Sandra Price.
Thank you, everybody. My board and I, we would like to thank the Palm Beach County chapter, Charmettes, Inc., for giving me this platform to bring awareness about bile duct cancer in memory of my identical twin sister, Tanya Gail Ingraham. For the ones that don't know, February is the month to bring awareness about gallbladder and bile duct cancer. And if you also don't know, our ribbon color is green. Every cancer has a ribbon color, and every cancer has a month that they bring awareness to. I'm gonna talk a little bit about my twin sister and her desire for me to bring awareness and start an organization. And that was her main purpose. That was her request before she passed away. My sister got diagnosed with bile duct cancer in July of 2015. She was having, for 6 months, she was going back and forth to her primary physician, trying to find out. She started losing weight, unexpectedly just losing weight. She had itching of her skin. She had lost her appetite, and she said she felt full all the time. She was also starting to have fevers at night. And then her eyes became yellow. So for 6 months, she went back and forth to the doctor, and they did blood work. They were running a test, and her hemoglobin count was also low. So she was also up under the care of a hematologist at the time. One day I got a phone call from her, and she said, Sandra, I threw up some black stuff. So I told her to immediately go to the emergency room. So she went to the emergency room, and then that's when they did a CT scan, and they discovered a large mass in her liver. She stayed into the hospital for a day or so and got discharged, and she was told to immediately go and see a hematologist, which she was already up under the care of. And then that's when we got the diagnosis that she had bile duct cancer. And of course, we were shocked because we had never heard of it. So he was trying to explain to us, what this was about, but we're already shocked that we just heard the word cancer. That's all we heard. And from there, we came back in 2 weeks, and he told us that she had the intrahepatic bile duct cancer. Then eventually we found out her stage, and she was stage 3. So we were all in a tailspin, distraught, didn't know what to do, just confused. And then I got on the internet and I started reading it, and everything I read was just horrible about bile duct cancer. So it was just a very painful experience. So she immediately went in to have an operation. They wanted to try to see if they could remove the tumor. So we went to the University of Miami to have her surgery done. Well, at Jackson Memorial to have her surgery done in Miami. And halfway through the procedure, the doctor came back out and told us the mass was sitting on a main artery to her heart. So we couldn't remove the tumor. Another blow. After that, we got that diagnosis. So we went immediately, she started chemo to try to shrink the tumor. With bile duct cancer, it's very aggressive. We were already told that it's not a cure for bile duct cancer, but if we can just get the tumor removed, she would have a better, higher survival rate. We focused on that. And when you have bile duct cancer, you're really on an emotional roller coaster, because you can go from the tumor starting to shrink. You can go 1 month and they're telling you that the tumor is shrinking, and then the chemo is working, and we're getting all excited because We know if we can get the tumor to shrink, she'll have another opportunity to have surgery to remove the tumor. Then you go back another month and the tumor has grown again. So we went on this journey, was just going on this journey. And then eventually the tumor did shrink and she had another opportunity about a year into her fighting. She had another opportunity to have surgery. So we set surgery up. Because I had already been through the first process, I'm watching her on the screen, how they're giving us updates. And I just knew 40 minutes into the procedure, everything stops. And the doctor comes back out and he delivered another blow. Her cancer had metastasized because they had to take her off of her chemo for 30 days before she did her surgery. So I'm just assuming, I'm not sure, but the doctor believed that her cancer metastasized after she got off her cancer treatment. Another blow. After that, she went through that. We got back into fight mode and we just started seeking out clinical trials. And my sister was the first person to be approved at the Tampa Moffitt Center. There were only 3 people. She was the very first one to be approved for immunotherapy back then. She did that for a month and we would drive every week, go up to Tampa for her to get her treatment, come back home. We did that for a month and we received the devastating news that the immunotherapy didn't work for her. Again, we were crushed. Tara was with us. After that, we got right back in fight mode. And we went to MD Anderson Hospital in Texas, seeking treatment. We got there and we met a wonderful doctor there that gave us hope for more treatment. He did have more treatment for her. He gave us more hope. But after we returned home, she
take your time. Take your time.
I'm here, sis. I'm here.
After she got home, after we got back home, she took a turn for the worse and passed away 2 weeks later. It's been a hard journey. It really has. Bile duct cancer, it's on the rise. I don't believe it's as rare anymore as people think it is.
Take your time.
I'm just saying to all of you, with any type of illness, be your own advocate. She fought really hard. She did everything that she could for the sake of her children, her family, for all her friends and everyone that loved her. On her journey, she also, provided support to other ones that were fighting different cancers with her as well. She was really the strongest person that I know. Everybody says that I'm strong, but no, she was the strongest person that I know. Be an advocate for your health over your health. Don't be afraid to get a second or a third opinion. There's nothing wrong with that. Any doctor would not be upset if you decided to seek a second or third opinion, as we did. We had a very supportive doctor here, and whatever we wanted to do, they helped us along her journey. In 2018, after my sister passed away, after fighting for 20 months, she fought really hard. She fought 20 good months. And she asked me to continue to bring awareness, spread awareness about bile duct cancer. And I have committed the remainder of my life doing this. I formed Tans Angels Forever, Inc. in 2018. And it was amazing after she passed away because she always said, I wish I could find one person that had my type of cancer. She knew people that had breast cancer and other cancers. And she said, I wish I knew one person. And after she passed away, I started coming in contact, and we created the organization. I started coming into contact with more and more bile duct cancer patients. And to date, because of our organization, we had a couple of bile duct cancer patients where I referred treatment to. And one is an 80-something-year-old man. I'll call him Mr. H. He's still alive, and he's been fighting for 2 years. And another young lady, she passed away recently. She fought for 2 years. She was 36 when she passed away, but I helped her on her journey. I heard Dr. B say that these cancers are common in women, and they're mostly 65 and older. I can tell you about this cancer because I'm in several bile duct cancer support groups. They've had a 9-year-old get bile duct cancer. A lot of young women and men are getting this cancer. I don't believe it's no more the elderly getting this cancer, you know. So we just have to, you know, just be vigilant over our bodies and our health, and, you know, and just pay attention to our bodies and get the necessary screenings and do the best that you can with that. Our organization to date has donated over $8,000 to bile duct cancer research, which we are in partnership with an organization in Akron, Ohio. It's called Crane's Cholangiocarcinoma Crew. 100% of all the money that raises for her organization goes 100% only to research. So we partner with them. We have also given out over 300 gift bags to local cancer treatment. Our organization not only educate and bring awareness to bile duct cancer, we also provide resources and support to all types of cancer patients. So we have delivered gift bags to the VA hospital in Riviera Beach, the Joe DiMaggio's Children's Hospital, and Memorial Cancer Institute. Another one of our issues, we just started this last year in 2020, it's called 10 Angels Grant of Hope, where we have provided financial assistance to 53 cancer patients by giving them monetary money, whether or not $100 Visa gift cards or money, so that, especially when the pandemic hit, they were high risk and a lot of them were not able to work. So we did that. We also send out 10 Angels care packages of hope. Uh-oh, what happened? I'm sorry. We also send out 10 Angels care packages of hope that have essential items that cancer patients can use. And I mail those out throughout the United States. Because I do get phone calls from people seeking treatment from throughout, whether or not they're in Washington, Philadelphia, wherever they find out about our organization, we assist them. And that's pretty much all what I have to say. And again, I thank you to the Palm Beach County Chapter Charmettes as well for partnering with our organization. We're going to be handing out, they made these beautiful gift bags, and I named them gift bags of hope, because everything that our organization, we try to bring hope to those that are fighting cancer and seeking treatment. A lot of cancer patients sometimes feel like they're forgotten about, and just little items like that, it just gives them that will to continue their fight. So I just want to thank you all for partnering with 10 Angels Forever Inc. And I'm just honored to be here. I also want to recognize, I have some board members that are here. Sonia Knight and Dickens, I think she's in the chat. And Margaretta Kierson is in the chat. And my board member, Gregory Newborn and Tamika Payne. Lastly, I want to say that bile duct cancer, I wanted to say that earlier, but bile duct cancer, people that are fighting bile duct cancer, and they don't call themselves survivors. They call themselves, because there's no cure for bile duct cancer, they call themselves NED, which means no evidence of disease. So that's another thing that I want to pinpoint having bile duct cancer is just a constant battle with that. Again, thank you, Dr. B, for the wonderful presentation, how you outlined it and you made it so easy to understand this very complex cancer, gallbladder and bile duct cancer. I mean, I understand everything what you were saying, but you made it so easy for everyone else to understand what this cancer is. Thank you.
Thank you.
Thank you so much, Sandra Price. And at this time, next on our agenda, we have our question and answer by Felicia Harvey.
Thank you, Sandra, for telling your story. Many know we work together, and I used to watch Sandra at work when she was going through. Courageous, strength. Her picture is in the dictionary. So I'm a little off topic, and I'm sorry, I'm a little emotional. She gave me hope in my time of despair, and I want to say thank you. Back to it. Come on. We didn't have any questions for Sandra. Maybe Dr. B can answer this question. And the question was, are there any preventive measures that can keep the gallbladder and bile duct? I don't know if they were saying healthy or on that question. The young lady that presented this question was Miss Antonia Spence. Maybe you can elaborate on your question that you were asking.
Yes, healthy.
Okay, healthy.
Yeah, first, I just want to take the opportunity to thank Sandra for sharing that story. It's the reason why I do what I do. Exactly what you experienced. And I think it's important for all of us to recognize that. I think you said it perfectly. This is a diagnosis that challenges a lot of people, a lot of ideas with regards to how to treat it, to find the best way. So I think one of the biggest things that we do with regards to surgeons and surgical oncology is to make sure that we personalize your care. And if it means even getting a second or a third opinion, I think that's a good point too, with regards to doing that. And I really appreciate your story. It's something that I take to heart. To answer the question with regards to just, maintenance of a healthy biliary tract, there have been some studies that have looked at that specific correlation to that question before as far as diet. And there are some things with regards to, again, because we're dealing with some things you can control, some things you can't. I personally haven't seen a patient that young at 9, but it does explain, especially when you have predispositions to these cysts forming in the bile duct that over time can lead to cancer. My youngest patient was 25. Again, it's not something that really follows the norm. And you would think that if there's something that environmentally that we can control, meaning our diet that we can control, it shouldn't be something that a 9-year-old should ever have to suffer with, a 25-year-old should ever have to suffer with. But for the more common population that, if we do see this, those are things that I would say are a result of just perpetual inflammation in the gallbladder. And as a result of that, some of it does seem to be dietary related, where it's reducing the fatty consumption, meat products, specifically red meat and things like that, where bile is used to help digest those foods. And in that context, I think it's really just a healthy diet and then trying to focus on those things that we can control. But, as Sandra said, sometimes the cure is prevention. And if there's something that you can recognize early with regards to your own healthcare, or recognizing and being an advocate for your own healthcare, paying attention to symptoms, it's key to try and prevent something from developing. If something just doesn't sit right, doesn't feel right, to get an appropriate workup. I think that's the best advice, because there's not something I can tell you or prescribe that's going to say that that's definitely going to prevent these things from developing.
I have one more question for Ms. Price. Can you tell us about the Colors of Hope luncheon?
Yes, the Colors of Hope brunch, we normally host that brunch in Deerfield Beach at the Deer Creek Country Club, Golf Country Club there. We've had two. Our first annual one was in 2018. And it's just a event that we normally sponsor about 20 to 25 cancer patients or survivors. They come out and we have a speaker. Not normally my sister's treating physician that treated her normally comes and she educates the audience on bile duct cancer. And I normally have a guest speaker. Whether or not my first year was a prostate cancer survivor, or over the hour, I normally have a cancer survivor that comes out that speaks. And it's just a great event. It's fun-filled. It gives an opportunity for the people that, you know, take their mind off of treatment. They get to dress up. It's a brunch. We have entertainment there, and it's all about continue bringing awareness. And I call it the Colors of Hope brunch because yes, I do educate about bile duct cancer, but I do provide emotional support and support to all types of cancer. So that's why I named it the Colors of Hope brunch. Hopefully after the pandemic, we can get back to doing it.
Okay, one more question. Is the immunotherapy trial that your sister participated in still ongoing? And do you know how much success has it had?
For my sister, it didn't have any success, but you know, it's been almost 4 years. Maybe Dr. B can answer that question about immunotherapy. You know, do they use it for bile duct cancer? Now, in a support group, I do know of people that says that they're going to get the immunotherapy, but I don't really, you know much about it anymore. Dr. B, do you?
Yeah, absolutely.
Okay.
So immunotherapy, you know, we're always looking for different ways to treat cancers. Immunotherapy is something that is used for gallbladder cancer. It's basically using certain medications to help your own immune system better recognize and destroy cancer cells. Most of the drugs that are being used as far as clinical trials also have other overlap to other cancers. So in terms of enrollment, it's not just gallbladder cancer, because as you can imagine, in order to show effectiveness of some of these drugs, they have to enroll not only gallbladder cancer patients, but lung cancer, other GI related cancers, and most of them are being tested in the context of clinical trials. There's a website called, if anyone on here is looking for more specific information about active trials that are enrolling and where they're located, there's a very simple website that's sponsored by the NCI, the National Cancer Institute, called cancer or clinicaltrials.gov, G-O-V. Two that I can speak to that are a phase 2 trial study is a drug called nivolumab and ipilimumab. And again, the label for that is used in treating patients with rare tumors. So they're using antibodies, these pharmaceutical drugs, to help your immune system attack the center or cells, cancer cells, to interfere with how it grows, it spreads. In terms of the effectiveness, there isn't anything that has necessarily been gone to completion as far as a clinical trial outside of pembrolizumab with chemotherapy. So you're using the chemotherapy drugs I talked about, gemcitabine, cisplatin, plus this drug pembrolizumab, and it's usually available for patients that can't have a surgery. So they're unresectable bile duct cancers. And in those patients, they did show an improvement with regards to months of survival. So it's not improvement in terms of significant years. But I do know that there are 11 centers that participate in that trial to specific for cancers that can't be operated on.
Okay, thank you, Dr. B. I have one more question for you, Ms. Price, and I have one more question for you, Dr. B. For those interested in making donations or contributions to your foundation, Ms. Price, how can they get in contact with you?
Okay, I have a website. It's called 10 Angels Forever, like they're on the .org. And you can make donations through the website. And you can also see the work that I have a photo gallery. You can see our pictures on there from our Colors of Hope brunch and some of the different initiatives that we do with Joe DiMaggio's Children's Hospital and things that we've been doing in the community. I want to also add, we also have provided service all the way from Fort Myers all the way down to Hialeah, Miami, dealing with cancer patients. So yes, I do have a website. And you can also follow 10 Angels Forever Inc. on Instagram, Twitter, and Facebook. We have a Facebook page.
Okay. Dr. B, as you mentioned immune system, what are your thoughts on cancer patients receiving the COVID-19 vaccine?
Great question. I mean, it's certainly bringing a lot of questions because most cancer patients were excluded from those clinical trials, but certainly the two new FDA drugs, Moderna and Pfizer, those patients, the patients that were in those clinical trials were not cancer patients, they were excluded, but we're certainly answering or at least asking questions, should those patients, because cancer patients are more susceptible to COVID-19, we've learned, but does that mean that they should be first in line for their shot or last, particularly if they're in treatment, because could the vaccine make them sicker? And especially patients that may have had cancer that's going through their body, can they get it if they're metastases? I can tell you that the current recommendation is that those patients, even those undergoing treatment, should go ahead and get vaccinated when it becomes available, specifically because of the susceptibility and because it is a condition that predisposes a vulnerable population to have a more severe infection, particularly if those patients are on immunosuppressive therapy. The idea there is to get the vaccine in between the cycles, because usually those treatments are separated by weeks, and you're looking at a vaccine that's either given in 2 doses, 3 or 4 weeks. So the recommendation there is, yes, that most cancer patients should go ahead and get vaccinated because they are more susceptible.
Okay, the last and final question. Dr. B, why can't the human body fight and destroy cancer on its own, and why can't the body heal itself from cancer?
I wish I knew the answer to that. It's one of those things that cancer develops by way of how our body attacks itself. There are certain genes that were pointed out in those videos, the proto-oncogenes and the cancer suppressor genes.
I did want to find out a little bit more about, I know we'll talk about it, about the father-daughter dance.
I'll say that just briefly, that because our body is in constant sort of battle between those genes, that sometimes it becomes a difficult balance to say how our body can fight. So I think immunosuppressive therapy, such as immunotherapy, and more personalized medicine, because what may work for someone's bile duct cancer may not work for another. And I think the more that we personalize that treatment and realize that not all cancers or react and behave the same, it may be more impactful. And that's what the goal of clinical trials are, and the availability of those trials.
Again, I want to say, now I have one more question. I'm a breast cancer survivor. I take anastrozole daily. I don't think I pronounced that correctly. Would that interfere with the vaccine and its effects?
So anastrozole is a sort of a maintenance hormonal therapy that majority of breast cancer survivors, congratulations by the way, do take for maintenance. And there aren't any studies, again, that would show with frequent drug interactions or anything like that. But the thought is certainly with regards to a population, and certainly we're seeing higher risk populations become at risk, that currently the recommendation is still to consult with your oncologist, but the overall recommendation would be to take the vaccine, because there's no way to predict the specific response or interaction. And we're learning more and more about reactions and side effects from certain medications that may overlap with either vaccine.
Again, I want to say thank you to Dr. B. Thank you, Ms. Price. Now I will turn it back over to Ms. Katura Howard.
Thank you so much. Thank you so much, Felicia, Sandra Price, President of Tanned Angels Forever, and Dr. B for the wonderful presentations. I'm going to turn it over to Cynthia Johnson for our vote of thanks.
Okay. This is, of course, I am not Cynthia Johnson. I am Audrey L. Davis Jones, the president of the Palm Beach County chapter of the Charmettes Incorporated. So Cynthia is having a hard time because of the various things that she is dealing with, and she asked me to just go ahead on and incorporate special thanks into my remarks. So therefore, the reason that I introduced myself, I'm coming up as Wanza Sermons Lee because I had to tag on to her to get in. I want to thank you so very much, Dr. B, for your presentation. Some of the questions that I had or had sent in was not put into the chat. However, your presentation was so complete and thoughtful and informative that it did answer my questions. And Sandra Price, I want to just thank you so very much for your warm and your heartfelt presentation as it relates from a personal standpoint. And I could speak of that on various occasions, but that is one of the best ways to get it out is through a personal touch and the personal experiences. So I want to thank you both for your time and your valuable knowledge and along with your expertise. I found that this event was very informative and yes, enlightening. So it seems as though even if you had questions, both of the presentations was able to answer questions that was in the back of our head or this lingered on. And I'm very appreciative of that. I'm also delighted for the exquisite six, our candidates for new membership who introduced this particular cancer to us. And one of the things is that our platform is the eradication of cancer. And I'm just so honored that this can also be included into part of a presentation. So with that being said, as always, the support of the Palm Beach County chapter members, I just want to thank you so much as well for getting, I did notice that we had 50 guests on the Zoom. So I'm very appreciative of that, because even in just getting the information out to one person, and if we could help that one person, we have saved a life or have prolonged it through the information that you have given us. So yes, we are the mother chapter, and this is just another tag that we can put in as the trailblazer of the organization of doing great and wonderful things, and especially into the community and bringing awareness to the different forms of cancer. So words cannot express, Dr. B and Sandra Price, of my gratitude for you coming on and sharing this very, very informative information with us. And I am so appreciative of you helping making this event a success. And it would be remiss of me not to mention my gratitude for the committee who is the lead in bringing this attention to us, and our committee chair, Couture Howard, I want to thank you, and all of the committee members for all of your hard and tirelessly work that you have put forth in making sure that we will be able to get this out to the community to let them know of the importance of this awareness. I want to thank you again so very much. I really appreciate your time, and I appreciate all of the information that you have sent forth. And again, we want to thank you, and I appreciate you greatly. Thank you. Back to you, Couture.
Thank you so much, Madam President. Thank you so much for that lovely vote of thanks and for your closing remarks. If there aren't any other questions, I see some hands raised. Tara, your hand is still up. Did you just forget? Okay. All right. So if there aren't any other questions, that concludes our presentation today. I want to thank everyone for being here with us, and please continue to look for upcoming events from the Palm Beach County chapter of the Charmettes Incorporated. We also added the links to Dr. B's clinicaltrials.gov and Miss Sandra's website, TAN's Angels Forever, to the chat box, so that you can go ahead and click on those two resources as well. We want to thank you so much, everyone, for joining us on this beautiful Saturday. And that concludes our presentation. Thank you so much for being here with us to support us. Have a beautiful day, everyone. Continue to be safe.
Are we taking pictures? Are we taking pictures, or can we go now?
Sure, Rosalind.
Okay.
Thank you.